Hi, this is Clara Anderson-Sante, Program Director with Gilda's Club, Kansas City, and we have Judy Waechter with us today, who is with Good Shepherd Hospice, who will be leading us through the conversation, what is it, palliative and hospice care? So go ahead, Judy.
Good afternoon, I guess it is, to everybody. So thank you for tuning into this, and I appreciate the opportunity to talk about this subject. It's near and dear to me, and there is a lot of confusion out there as to what these terms palliative and hospice care are. So the things we want to hit on is what is the difference between the two, who should have it, what's the eligibility for it, and why would I want to do it? What would it benefit me for? So I'm going to jump right in because we're limited on time, and like I said, this is an important soapbox for me, so I want to make sure we get to talk about it pretty extensively. All right, so palliative care is treatment for any symptom management regardless of what you have. All right, so palliative care is simply symptom management, regardless of whether you have diabetes, heart disease, lung disease, cancer, whatever it is, asthma. Those are things that I could only manage, but I couldn't cure. So congestive heart failure, emphysema, diabetes, asthma, they're chronic conditions. And anymore, oncology is often a chronic condition. So I kind of throw that out there sometimes too. But the disease, even if you are a perfect patient, the healthcare term, and you do all of the right things to manage your diet and your activity levels and your lifestyle, you still have normal progression of the disease and normal aging that goes on. So what you need at different stages changes. And that is symptom management of that condition that you're living with. And that's what palliative care is. It doesn't replace in primary treatment, so it wouldn't eliminate heart surgery. It wouldn't eliminate oncology treatments like surgery, chemo, or radiation, but palliative would work together with the primary team that is treating you for whatever you're receiving care for, with a goal of helping you to manage the symptoms that you're dealing with and improve the quality of your life. And we utilize physicians, nurses, social workers, all for different reasons. You know, we can't provide care without a physician order. They're the lead guy. They're the one that, or gal, that provide the direction and the orders, because you can't provide health care without a physician's order. And, you know, they're the subject matter experts. So that's who leads the team. And then the nurse is the one who's going to capture information, assess information, teach the individual and their family and friend caregiver group, whoever they live with or help support them. Social worker is going to be there for everything from counseling to helping with community resources. And then we're going to bring in the other disciplines as needed. So somebody might need occupational therapy. They may need speech therapy or physical therapy. The pharmacist to help look at medication reviews to see if there's a med that's causing some of these side effects, or is there a better med that we could use, or something where we didn't have to dose so often, and what would make things better. Dietitians, chaplains, and in many cases we use alternative treatments. So we might bring in chiropractors or acupuncture, massage therapy. There's a variety of different things that we utilize in palliative care to help a person manage their symptoms. And palliative care is for someone at any stage of an illness. Doesn't have to be a life-limiting condition. That's hospice. We're going to talk about that later. But palliative care, again, is symptom management. So we're trying to make someone's daily living better, management of their disease better, help them prevent unnecessary complications or high-risk complications, keep them out of the hospital, help them feel in control and able to manage their situation and not so overwhelmed, not to be so worrisome, and to help coordinate care. And this also involves working with whoever their support system is, because in those cases we're often relying on other family members that someone lives with. Maybe they live with a roommate or a significant other. It doesn't matter who their support system is. We want to make sure that that support system knows how to be of support to that individual. And this is all based on what an individual has determined to be their priorities. It's not up to us in the healthcare industry to dictate to you what matters to you or what you should find most important. This isn't an authoritative process where we just come in and slap you with a plan of care that says, this is what you must do, this is what you need to do, these are the best outcomes. It's more of an investigative process to find out what is it that's of value to you, what's important to you, what are the things you're concerned about. For some people, it may be, hey, I'm the primary breadwinner. I've got to have the health insurance. What's most important to me is work. So farming out the yard, the housework, the home maintenance, all of those things, feel free and give me some resources for help with that. But I got to be able to go to work. For somebody else, it's like, yeah, my employer will work with me. I can work part-time and I'll be okay because all the responsibilities not on. Okay. Again, it's being investigative. It's talking with the individual and finding out what are their priorities, what matters to them, not about what's the matter with them so much as what matters to them. So if a specific symptom is something that they want to address, we're going to address it, but everyone gets to decide how important that symptom is to them. It's not uncommon for some people to say, you know what, I'm okay being a little bit, weak or pale or under the weather or uncomfortable because I don't like to take all these medicines. It really makes me uncomfortable to be taking a lot of medication. Or, I'm sleepy, or I just don't think as clear when I take all of that. So I'd be okay to be a little more uncomfortable, but more alert and more with it. That would be more important to me. So we help individuals identify what is the most important to them, and then we work through that with that individual. So we provide services based on need. It has nothing to do with some cookie cutter situation where everybody gets the same thing. It is looking at what an individual needs based on their situation. We're helping everybody understand where things are at. And part of that is, will this get better? Will it not get better? What will it look like? How much can I recover? Because with many of these chronic conditions, I think of heart and lung disease as well as some of these others, we have a decline and then we help you out with some nursing care and maybe some therapy and you get a little better. Then we go on for a while and we come back down and we keep helping you tune up, but you don't ever come back up to here where you started out. So it kind of looks like a gradual decline over many years in a lot of cases. I can relate to that with my mom, who was an oncology patient and had 4 different cancers over a period of about 30 years. She often, in the early years, came back up to pretty much where she had always been, lived with some residual effects from earlier surgeries and treatments. So I won't ever say that she was back to her original starting point, but back to a very high level of function. We'll put it that way. But you go through 30 years and 4 different treatments, 4 different malignancies, different body systems, and they all play a toll on the individual. So we want people to understand what normal progression of disease looks like. We want people to understand what is most likely to happen, what to watch out for, what we can intervene on, and to start thinking early about how they want all of this to play out and what they want to do if and when those circumstances present themselves. And we're going to coordinate the care with the other healthcare providers. So if we need to do therapy, we're going to work with the outpatient center or the home healthcare agency, depending on which we're working with, to ensure that everyone is aware of what the symptoms are that we're working to address, what the causing factor is, what the plan is for treatment moving forward, those type of things. And to help not only ensure that you get the services that meet your needs, but that all of the other players involved are aware of it. Because we often end up with multiple physicians, which I'm sure most of you are dealing with now. You have an oncologist, you might have a surgeon, you have your medical oncologist who might be ordering the chemo and things. You've got your radiation oncologist that's on your team. You've also got your primary care physician that you're dealing with. And if you've got other underlying health conditions, you may have a physician for, OBGYN. You may also have a physician for cardiac issues or endocrine for diabetes, or maybe anymore it's like you've got a doctor for the left eye and a doctor for the right eye. It gets very, very confusing. We want to make sure that everybody's aware of what's going on, what's currently happening with you, and what we're doing to address it. So they're going to get updates. They're going to be asked sometimes for input, because what you do to one body part affects another body part. So we want it to all be cohesive, and we need somebody to be the designated grown-up, okay, the scout leader on this overnight here, and to coordinate all of that care, to be the lead communicator, and to gather that information and make sure it gets shared back and forth, so that we're all working cooperatively together and that we're not undermining each other's efforts. We're going to be able to help make recommendations to deal with whatever symptoms you're dealing with. So for instance, if it's issues about fear or anxiety, maybe the social workers are going to have a more prominent role, because they're going to be able to help you with not only resources, but with counseling. Perhaps it is dealing with neuropathy from chemotherapy. Maybe we need to not only deal with pain management in that case, but medication management, a lot of education to be done with that, some tips and tricks and tips on how to manage that and keep it from being such an issue for you. And maybe we need to bring in some occupational therapy there, because not only can they help with sequencing with chemo brain to help you be more successful and not so forgetful, but also to streamline your activities so that you have maximum energy conservation, so that your home is set up for you to be as successful as possible, and to help deal with the neuropathy. And they have a host of tricks up their sleeves to not only improve your quality of life and function, but to make it where you are able to be more self-sufficient and safer, especially when it comes to things like driving. I remember my mom saying, well, I'm just going to local, close places. And it's like, well, that's great, but you can't feel your hands and your feet, and you need all of those to drive. So again, it's helping individuals overcome whatever symptoms they are dealing with, which aren't always from the disease. The reason for the neuropathy is because of the side effects of the drugs that we're treating you with. So we give more drugs to counter those. There's that whole snowball effect that we want somebody overseeing and helping you with. And we give you these great resource books, the ones you get at the beginning of treatment, those notebooks. And most people find them about 2 years later stuffed under their bed or something, and you're cleaning and you pull it out and you're like, oh man, I should have looked at this back then, because this had some really good information. But we're so overwhelmed at the time with the volume of information that's coming into us that sorting through what's important and what's not is very difficult to do. The skills that they're going to teach us during this period of time help us stay at that maximum level of function based on whatever your goals are. So if that neuropathy means you need to be able to drive, and that chemo brain needs some sequencing because you got to be able to work, and you'd still like to be able to take your dog to the dog park because your dog's your best friend, and you want to maintain that relationship, and you like the people you see at the dog park, and when you're there and you got your baseball cap on, you look like everybody else, and it feels good to be outside and to look at the lake and feel the water splash and the sun and the wind on your skin, and just be a real normal person for a little while. Okay, then we need to make that happen, and we can. We want to plan for future needs about what your disease process or side effects could do moving on, or if there's a disease reoccurrence, those kind of things, and help you identify when you qualify for more help, because often we reach a point where the provider who ordered the treatment or the surgery or gave us the diagnosis is saying, well, yeah, that's just where it is. Yeah, that neuropathy, that kind of stays with you. Well, there's still something we can do about it. They may have ordered what caused it, but they may not be the same provider that treats the after effects. When we're working with professionals like occupational therapists, then we can have someone who helps us modify what we're doing and how we're living to be able to achieve what's most important to us. And I would encourage you, if you're not familiar with the Open to Options program that they do there at Gilda's, take an opportunity to find out about that. It ties in very, very closely to what we're talking about right now. So who's going to use palliative care? Well, anybody that wants to, basically. If you've got a symptom that needs managed, you qualify. Usually it's for someone who has a serious illness or event and they've got a progressive condition. So regardless of whether their prognosis with this is short or long term, you have symptoms that need managed right now. They may get worse or better. They may change over the years or the progression of the disease, or just because you went through it years ago and now you're living with the after effects. It doesn't matter at what point you are in your treatment. You might be dealing with effects from chemo that you had 20 years ago, because now we know that the chemo that we use to treat breast cancer tends to put us at risk for a lot of heart disease problems at an earlier age. So again, it may be totally unrelated to the original cause, but it's a symptom nonetheless. Having that assessment of the living environment to help with, again, setting up your home to be as safe as possible, as functional as possible, to maximize your independence, to target what is most important to you, to bring in the community resources available, whether that's home health or getting you involved with assistance in the home for things like lawn and house cleaning, or maybe it's, temporarily doing home health services because you're not able to go to outpatient therapy. Doesn't matter what the diagnosis is, doesn't matter what your age is. And in many cases, this may be somebody who they might have a life-limiting illness, but they've got years left. So they're not eligible for hospice, which is specifically for end-of-life care. Or in some cases, they would be eligible, but they're just not ready to go there yet. We can still provide you palliative care. That's why we have the Patient Self-Determination Act. You, as the patient, as the individual, you get to decide what care and what treatment you do or don't want. You get to drive your own bus. We'll give you the information and help you to understand it so that you can make an informed decision, but you get to choose what you're going to do. So who would be best suited? It would be anyone living with that serious illness that requires that management of symptoms. If they are dealing with any physical or emotional pain that's not under control, a lot of our issues that come up with medical conditions are what it does to change us as an individual. Not only how we saw ourselves, but our ability to function at the level that we were previously. We need help to understand what's going on, what this new situation is, because we've got a diagnosis, we've got preliminary testing to be done to see where we're at and if we're cleared for surgery, and then we've got to get through the surgery and the recovery, and then we're looking at treatment options and how we're going to respond to those. And after a while, what we thought we understood is just getting very blurred and confused. So we need people to help us figure out where we're at and where we're going. Unless you work in healthcare and in the same area of healthcare that your diagnosis is, all of us are learning as we go through these situations. And we need someone to help us coordinate the care between all of our healthcare providers. Most of you are familiar with the term the nurse navigators. Well, we have case management, we have care coordinators, we have nurse navigators. All of us need assistance through this period of time because it's gotten very complicated and it's overwhelming. And we need emotional support. This is a lot to take on and to go through and still manage all of our additional responsibilities, as well as for those that are helping us through this. It's overwhelming to them. They probably weren't prepared to be a caregiver at the time that need arose, and they probably haven't had any formal training in being a caregiver. So some of the differences when we talk about different levels of home health care and palliative care and things, if I am providing you this care under a home health care license where we bring in the nurse, the PT, the OT, speech, hospice, or excuse me, a home health aide, whatever it is that you need assistance with, social work, you still have to meet the criteria for being homebound, which means you're unable to go out for your healthcare treatment. So even though we can provide all of those under home health, we still have to meet that homebound criteria. And I want that to be really clear for people, because some of these things get said and terms used interchangeably, and it can be confusing. You might or might not still be receiving treatment like chemo or radiation. We're looking at assessment for risk because we want to prevent a crisis. We want to prevent deterioration. We want to educate you on what to watch for and what to do to help keep you out of the hospital. And when we talk about things like the avoidable readmissions and things like that, Medicare and health insurance have specific guidelines on how many and how often. So people that have been in the hospital that are readmitted within 30 days, they want us to keep that number to less than 1%. So we put a lot of effort out to do this. And if you're getting home health services and are homebound, that's about as vulnerable as you can get. I need this level of care and I can't even get out to go get it. Okay, it's just barely a step down from the hospital. So we want to make sure that it is something that the family and the caregiver support team, as well as the individual, understand is maybe not in home around the clock care, but it's 24/7 access. So there's always on call to call and walk you through things, triage things, set you up with a home visit, whether 10 o'clock at night or whatever it is that you need followed up on. Maybe it's something that can wait till a visit the next morning, or maybe you do need, to go to the emergency room, but they're available to triage it and walk you through it. And if at all possible, we're just going to come out to the home and treat you there and prevent that hospitalization. And this level of care could be during treatment. It might be when you're in a remission. Maybe things are just in a stabilized period, but you know there's going to be more rearing its ugly head later. But right now, things are stable and you're between treatments, those kind of things. Some of the things that we look at when we talk about whether or not palliative care is right for a specific individual, we actually have, through the National Hospice and Palliative Care Organization, some really good tools and tips that are out there to help people determine if they need that level of care and what that level of care would look like. And I put all of these references or resources on one slide at the end so that you could do some research on your own. They have links on there for individuals and for patients, families, caregivers. It's worded different ways for different audiences, but I wanted you to be able to access those on your own. So these are some of the common disease or serious illnesses that would make someone appropriate for palliative care. And if these symptoms are something that you or someone that you're caring for is experiencing, this would be another indicator that palliative care would be an appropriate level of care. And you can see that it covers quite a variety. So these are physical symptoms, but we also have to keep in mind that because of these physical symptoms, we are going to see a lack of energy, a lack of endurance, a lack of function, and that the individual needs more assistance and more self-help. So that functional ability is a huge piece of determining whether or not a person would benefit from having palliative care, because pain is going to inhibit our ability to perform our self-care. Being anxious will, anxiety and shortness of breath go hand in hand. Not only can we teach energy conservation and the pursed lip breathing to help manage anxiety and pain and reinforce it until you're able to do it automatically on your own, but we can help you triage which medications to use and to take and when to use those and how to time your activity around those so that the brunt of that effort is being done during the time that those medicines are at their peak performance. And they can take the brunt of it and you come out maybe not smelling like a rose, but if it's a good enough shower, it will. But you're able to do the therapy. You're able to do the self-care. You're able to walk the dog. You're able to get through a day at work. Depression is, quite frankly, a normal response to these situations. You should be depressed. You're in a cruddy situation. That's a normal response. That's okay. Let's help you with it, whether that's supportive counseling or medications or a blend of both. Maybe it has to do with activity and diet and sunshine and attitude and resources and diversion, but we can help you with all of those things. Fatigue. This is an ongoing issue with most treatments and most serious illnesses. So let's help you address that, because we all are different. We have different sleep habits and we have different needs, and what you never needed before or always did before may not be what you need to do now or how you're going to operate now. So we're recalibrating. We're coming up with a new norm, and it may be temporary because things continue to change. Whether they improve or whether they decline, they're always changing. The appetite, that can be a really big deal, because when you don't want food, when you're not interested in food, and when it doesn't taste good, but what's everybody trying to get you to do? Eat. A good friend of mine who dealt with colon cancer at a young age, I used to laugh that when I would leave her house from being over there to help her with herself and her young son, I seemed to be one of the few people that always left there with more than I came in with. And it was because a well-meaning relative had set her up with one of those home deliveries of fresh produce. And it was a kind gesture, and they lived out of state, so this was something they could do to be supportive. But as she said, if I've only got room for 5 or 6 bites, I'll be darned if it's going to be broccoli. In her situation, she wanted to eat things that she enjoyed the taste, that gave her some calories, and she really wasn't in a situation right then to worry about how many servings of fruits and vegetables she was getting. So again, it's that piece of pleasure eating, what appeals to you, what tastes good right now, and what can your body digest. Because broccoli, it's not a food that the body digests easily. It takes a lot of effort on your GI tract, and there's a lot of side effects with bloating and gas and distension, which cause pain and discomfort, which causes anxiety, which leads to problems with nausea and constipation. So again, it's helping to maximize function, identify what the needs are, and work with an individual to get them to the level of function that they want to be at. So we want to know, are you or someone that's close to you having side effects from treatment that are making daily life difficult? Is it impacting your ability to eat? Whether that is nausea, whether that is dealing with a quick feeling of fullness, it's oral lesions and sores, it is problems chewing, it's weight loss and your teeth don't fit. It could be a host of things. It's how certain foods just turn you off. And sometimes you never turn back onto those foods again. They're just gone. Are you having frequent emergency room visits? Something's wrong and I need help. And sometimes this is because something is wrong. Maybe it's nausea or dehydration related to that, a urinary tract infection, a fall, all kinds of things. But sometimes it's fear and anxiety. Something has happened. I'm afraid that something with my disease has changed and gotten worse, and we have an anxiety issue, and we end up in the emergency room, and there isn't something actually changed, but whatever that little event was, it was enough to raise concerns. So we would like to have a lifeline for you so you don't always have to run back and forth to the emergency room, which can be exhausting and many people say embarrassing. And if someone has been back in the hospital 3 times or more within a year with the same symptoms, then we don't have them well managed at home, and we can do better. Do you need help understanding what's going to come next, what to expect, and what programs or resources are actually out there and available to you? And do you need help to sort through the information and to answer your questions so that you can make medical decisions about your options and clarify them before you make a choice? Which is where Open to Options with Gilda's Club is a great program once again, because you leave that session with your social worker after that guided conversation with a concise, coordinated list to go back to your next healthcare provider appointment, knowing what your medical questions are, what your medical goals of care are, and what your personal goals of care, your personal questions you want clarified are. And it allows us to have control of that appointment, to get the information that we are really desiring that's important to us so that we can make informed decisions moving forward. We want to help take those goals and your values and match it to the appropriate medical care, because there's a big difference between a physician saying, well, this is what we do, and you saying, well, that's not what I want. Doesn't mean we have something else to offer you, but it may mean that what we have to offer you is actually worse than living with a disease. Knowing the pros and cons, meaning the benefits and burdens of treatments, both if you do them and if you do not. What will it look like if I do it? What will it look like if I don't do it? And that comes into play with a lot of things, whether that's chemo, surgery, radiation, dialysis treatments, those kind of things. Next question we look at is, what about how are you coping? How are you doing with the stress of living with this serious illness? Where are things at with emotional support? Sometimes our caregivers are doing the best they can, but they're having a hard enough time holding it together themselves with these new roles and learning all this new information. Maybe there's spiritual or religious support that you want or need that isn't available to you currently. And maybe you need help. Maybe you need help for your family to understand what's important to you. I remember a really wonderful lesson I learned from a woman at Gilda's Club, and we were in a support group for people living with recurrent or metastatic advanced disease, life-limiting conditions. Living with dying, basically, was her situation. And she had 2 young adult children and was at this appointment or this session with her daughter, who was very supportive and understanding of her mother's situation. But she had a son who was very uncomfortable with the fact that there wasn't treatment options left for his mother, and that her disease was probably going to be the thing that she ended up dying from, and in the near future. She needed help to be able to talk to her son and help him understand that this wasn't what she wanted, and that yes, we have done all that we can do, and at this point we need to look at some different options and help me live as well as I can for as long as I can. Different payment comes under Medicare, Medicaid, and private insurance depending on what your situation is. And then, didn't mean to move quite so fast from that, we will help you to determine what they will or won't cover, and to make sure that we maximize your benefits so that you get the most out of what's available to you. The time frame that this flips over into hospice, because all hospice care is palliative, although palliative doesn't necessarily have anything to do with hospice. Once we use the term hospice, this is the opposite of pediatrics. We have neonatal and newborn and pediatric care for the beginning of life, and we have hospice for the end of life. And it is a natural progression, because regardless of whether I work in hospice or not, death was inevitable for every living thing. Hospice is a philosophy of care. It's not a place. It's patient-centered. We treat the person, not the disease. We're much more concerned with what matters to you than what is the matter with you. It is dealing on quality of life, and your needs and those of your family and friend caregivers is what drives the decision process. And the care is provided wherever an individual lives. So we bring the care to you without having to meet that homebound criteria that we were talking about earlier with home health services. We can do routine intermittent visits where we come and go from your home, your assisted living, your nursing home, wherever you reside. That includes the disciplines of your nurse case manager, the social worker, the chaplain, home health aide, and even volunteers. If you were in a situation where you were having an exacerbation of pain or nausea or shortness of breath, something like that, we can do continuous care right there at your home and not send you back to the hospital, and give you the opportunity to be treated in your own home, and for us to coordinate care with your physician and get the appropriate treatments and medications or equipment into the home so that we can get your symptoms managed again. If for some reason we're not able to do that in the home, we have contracts with area hospitals and long-term care facilities where we can admit a patient, an individual, to get those symptoms under control when we aren't able to do it in the home. And in that case, we get the symptoms under control, we get on our new regimen, we teach the family what to do, and we return back to that home environment. Or in some cases, the individual may remain on that inpatient admission through the last days of their life if their care needs are going to be more than can safely be met in the home. And then we have respite care, which is specifically for relief of the caregiver, that allows an individual to be cared for up to 5 days at a time so that the caregiver can get a break. And I have used this in the past where an individual who was the caregiver came down with a diagnosis that required surgery and follow-up chemo, and the adult children weren't going to be able to take care of her and dad, who had advancing Parkinson's at that point in time. Not when everybody was down at once. And mom was really doing okay, except that 1 week after chemo, every 3 weeks when she would have a down week. We would admit her husband for a respite stay because he was the one that was on hospice. And he would be cared for in a facility for up to 5 days so that she could recover from her treatment. And it was a huge opportunity for him for the first time to be able to give her something. And that was the reassurance that she would be okay after he was gone, and that she would be okay after her treatment was done, because she had a very high recovery rate that was expected. But caring for him carried a lot of guilt because he already felt responsible that she hadn't caught her disease earlier because of being so preoccupied with caring for him. So we were able to support both the family through that process, all under a Medicare benefit that covers the individual's medications, durable medical equipment, and all of their hospice team with the Medicare benefit or under commercial Medicare or Medicaid. So this is for folks with very serious life-limiting medical conditions that are not compatible with life, who, if the disease did progress at its normal progression, would probably be terminal in about the next 6 months. It doesn't mean the person will die. It simply means that their condition makes it a very realistic possibility. And these are folks whose diseases are life-threatening. The conditions that they're living with make their day-to-day life very challenging, whether it's physical discomfort, emotional, or spiritual. They have changed priorities from treating their disease to focusing on quality of life only. They need management of any symptom, pain, nausea, fatigue, shortness of air. We've listed several there. And they are maybe seeking hospice just because of the anxiety and the depression, the emotional and spiritual needs, not physical needs at all, but these other issues that come up and cause distress as a secondary effect of their medical condition. And they need the services of us, hospice, to help ease their discomfort and their distress at any stage in this. And as I said, this is about living. It increases a person's quality of life, but also their length of life. We know that if we're allowed to come in and provide care earlier on, not only can we provide the care more cost effectively, in fact, 1 month of routine hospice is the equivalent of 1 ER visit, but also that we can prolong life, that the average life expectancy of someone who utilizes the hospice benefit is about 2 to 4 months longer on hospice than not. And that is because the initial Medicare hospice benefit is a certification period that allows the individual to receive hospice under a 90-day certification. So you automatically qualify for 3 months. The end of that, if you still meet the criteria, another 3 months, and then we continue to recertify indefinitely every 60 days as long as you meet the criteria. And that varies depending on your disease or your diagnosis. We want to help you to identify what means hope to you. And again, that's just because their disease or your body has reached a point that a cure is not likely, that doesn't mean that there's nothing left to do. In fact, the more needs you have, the more help we're going to layer on to ensure that your quality of life and length of life are as good as possible, to live as well as you can, as long as you can, and focus from what's wrong with you to what matters to you. No deductibles or copays under Medicare. All of your services, meds, and equipment related to your terminal diagnosis are covered. Those are ordered and delivered by your hospice team. Medicaid can vary, but it is pretty similar state to state and covered. And your private insurance can vary as well, but we'll help you work through those things. We talked a little bit about certification periods. I want to make sure we have time for questions. And I'm going to let you look at the discipline-specific things that we do. I've listed all of those here: your physician, your nurse and hospice home health aide, your social work and chaplain, grief support, and volunteers. Unlike other areas of healthcare, we have a hefty volunteer program and department, and our bereavement services begin while the individual is on service, receiving our care, and continues with their significant others after an individual has passed away for over a year. And we know that how those folks will do after someone has died has a lot to do with how they go through that experience. And we want to make sure that they are as well prepared for life after as possible, which is also very reassuring for the individual, because this does provide an opportunity to tie up some loose ends. And we're there to support those individuals as they recalibrate their relationships in their life to this new role without the individual that they cared for being present any longer. These are the resources that I mentioned earlier. I wanted to make sure you were aware of those. The Missouri Hospice and Palliative Care Association has a very easy to use website. The national one, much more information and very user friendly. Some of the information I brought in came from the Journal of Oncology and Archives from Internal Medicine. And we are at 12:42, which means I need to stop. And I wanted to let anyone who had questions, I'll turn it back over to Clara, but allow anyone who had questions to ask those.